Okay, good morning, everyone. On behalf of Dr. Borak, Dr. Jossel, and the Department of Medicine, it's my distinct pleasure this morning to introduce my colleague and friend, Dr. Dena Rifkin, who will be presenting medicine grand rounds this morning on an interesting topic that I think you'll all enjoy and find insightful. Dr. Rifkin was raised just outside of Boston and completed high school there and did her undergraduate work in computer science at Harvard University. After graduating magna cum laude and Phi Beta Kappa from Harvard, she matriculated at medical school, initially at Stanford, and then transferred to Yale, where she graduated AOA. She then remained at Yale for her internal medicine and internship and residency, as well as a chief medical resident year, all at Yale, and then moved closer to home back to Boston and completed her nephrology fellowship, both a clinical and a research fellowship at Tufts School of Medicine, which will become relevant to today's talk. I had the pleasure of meeting Dr. Rifkin somewhere in the middle of 2008 when she knocked on my office door for an interview considering a move to the West Coast, and have really been delighted to work with her ever since. It's been amazing to watch her career move forward. She moved through the ranks and became a professor of medicine, or professor of clinical medicine in the clinical extract in 2020. She is truly a triple threat. She has more teaching awards than some people have on their publication lists. She seems to get new awards every year, not only from the medical students and the residents, but also from our fellows. She's an avid researcher focused on blood pressure and is leading a clinical trial at the VA, and is an outstanding clinician as well. Today's topic is a very interesting one titled Inclusion, Accuracy, and Race in EGFR. And I mentioned her training at Tufts, which is relevant in that the division chief and her part mentor at that time was Andy Levy, who developed and really implemented many of the EGFR equations that we all know from our clinical practice. And so I think that will inform her presentation today. So Dr. Rifkin, thank you so much. Looking forward to what you have to say.
Thank you very, very much for that introduction. I'm really thrilled to be here and thrilled to be here to talk about really 100-year journey in work toward inclusion and accuracy as relate to kidney function in this setting. But really, this has been a thought project in so many different areas as we re-examine our notions of what a representative population is and whose data we use when we generalize and think about estimating anything really medically for larger populations. So this slide has the timeline that I'm going to go over today as relates to kidney function and race. But Dr. Jossel always asks that we give some personal introduction, and I thought that one way to give a personal introduction would be to reflect on that same timeline in my own family's life as relates to gender equity and inclusion. So my family's, along the maternal line, my family's story starts really in the United States when Etta Bittner immigrated at the age of 16 to the United States, fleeing anti-Jewish violence in Eastern Europe with her family. She settled in New Jersey, and my grandmother was born there on a farm and became the first to go to college, earning a teacher's degree at Hunter College in New York. She taught until she was married, and at that time it was essentially unheard of for a married woman to continue to work in that time and place. And so she retired from employment at the age of 18 when my uncle was born. My mother walked through doors that my grandmother and great-grandmother opened to not only attend college, but to earn a PhD in organic chemistry at the Massachusetts Institute of Technology. But there were still doors that were closed to her, and in her search for a research career, she found it very hard to find employment. Ultimately winning a class action lawsuit against Dow Chemical, which had discriminated against women on the basis of sex in hiring. She went on to a successful teaching career at Boston University, and I was born in 1974, and I walked through many doors that my mother's and grandmother's and great-grandmother's generation opened for me in order to achieve some of the things that Dr. Ix mentioned. So now the question is which doors we need to open for the next generation. And that's a theme of this talk. But when we think about this in terms of my daughter's generation, what doors do we need to open in terms of equity? Well, we might start by having grand rounds at a time other than 7:30 in the morning when people and their partners are trying to get their children to school, and acknowledge that 7:30 in the morning is no longer an integral part of our professionalism. When my daughter gets to work, I hope she's paid more than 75 cents on the dollar, as women in our generation have had to tolerate for many years. And I hope that in the future, women and anyone with time-consuming extracurricular activities outside of their professional existence can continue to work without having to compensate for the inadequacies of systems, which I think is something that we've seen so clearly in this pandemic as problematic. Now, it's March that's Women's History Month. This month is Black History Month, and I'm mindful that I'm not a historian, and I will never experience anti-Black racism personally, but I hope that I'll be able to bring the same empathy and passion to the story that I'm about to tell you about race and kidney function as if it were my own story. So this is the timeline that we're going to follow, and I hope that you can learn as much as I really have thinking about these issues, not just over the last couple of years, but really over the last decade, examining what it is that we consider when we think about race and kidney function. So our goals this morning are to understand the historical context of what we consider to be a representative population when we apply data from medical epidemiology, to understand how race got into estimating equations and weigh what people saw as the benefits initially, and also understand the risks and the harms of inclusion of race in a kidney function estimating equation. I'm going to share with you an alternative race-conscious kidney function assessment that goes beyond our current typically used metrics of kidney function in the form of estimating equations that use a different marker called cystatin C. And I'm going to encourage you to think beyond GFR estimates in thinking about kidney-related health disparities, because truly, if we think that we have solved every problem by changing an estimating equation, we will have failed to open doors to the future. So it's always fascinating when something that one has spent so much time studying and thinking about makes it to the front page of the New York Times or makes it to the radio. So this is, in the last year, a number of articles fueled by the Black Lives Matter movement and also by intensive activism by medical students and physicians to rethink the inclusion of race in a number of digital calculators. And this article in the New York Times talks about not only estimating equations for kidney function, but other places where race has been baked into our clinical calculators. NPR spent 14 minutes on the topic of whether Black people should get race adjustments in kidney medicine. This was certainly a driveway moment for me as I listened to this on the radio. And in our medical literature, again, questioning the idea that nephrologists, known for being people who love to calculate things and love to think of ourselves as extremely precise in our calculations, we're willing to accept a binary race variable, either African-American or not African-American, in our calculations of kidney function. So this existed for 20 years before 2021. How did we get here? Why is race in the equation? And what is it that we're even doing when we say that we're calculating a GFR based on, calculating an estimated GFR based on demographic data. I want to take you back to medical school for a moment to talk about what is the basis for all of these calculations. So all of us are familiar with looking at chemistry panels. We look at them every day. On that chemistry panel is serum creatinine. And creatinine is actually quite different from many of the other numbers on that panel. You would never think about having an adjustment equation for potassium. Potassium is bad for, if your potassium is greater than 6, it's bad for you. If I put an IV in my left arm while I'm giving this talk and infused potassium until my potassium level was twice the upper limit of normal, we would have a real problem. Somebody else would have to complete the talk because I would be dead. But creatinine is just a biomarker of, generally thought of as a biomarker of muscle breakdown. And the reason we measure it is not because we're interested in the creatinine level. It's because we're interested in what it reflects about kidney function. And it happens to be a biomarker or a substance that is freely filtered by the kidney. And so it's an endogenous marker of kidney function in that it's filtered by the kidney and secreted a little bit, but we can use it to approximate kidney function for that reason. It's convenient because our bodies all make it. Now, if our bodies made creatinine, if every human body made creatinine at the same rate, this talk would also be over very quickly, because then we could treat people with the same creatinine level as if they had the same kidney function. But it turns out that's not the case. That because creatinine is cleared, if you remember UV over P from medical school, we need to understand creatinine production in order to understand what it means for kidney function. And creatinine production may be very different from one individual to another, okay? And we can go from measured serum creatinines that are exactly identical across different individuals to very different clearances, very different kidney function. So if we understand that a frail person, a person who uses a wheelchair for mobility, has very different creatinine production from a larger person, versus a woman versus a man, a child versus an adult, that what we really care about here is kidney function, we need to calculate a GFR, an estimated GFR, or a creatinine clearance. I'll use those interchangeably in this talk and just talk about kidney function as the thing we care about and creatinine as the thing that we're capable of measuring. Many of you have probably tried to collect 24-hour urines to understand creatinine production, and it turns out that this is very cumbersome to do for your patients. It's cumbersome to do even in a hospital setting, and so that middle number is often not known. What we care about is kidney function. What we can measure is creatinine. If we treat everyone with the same creatinine the same, we will be overdosing or underdosing medications. We will be misdiagnosing their disease. So from here, with that middle number unknown, what equation developers tried to do was to use available data to guesstimate what people's creatinine production would be, using research populations in which those numbers are measured. And this is key. So in the research populations, we have the 24-hour collected urines, or we have a research measure of kidney function where inulin or iothalamate are used to actually measure GFR. And another key here is that this is a very uncomfortable marriage between nephrology and creatinine, because we don't actually care how much muscle people have that are that's generating creatinine. We don't really care where it comes from. We know that it's roughly related to people's overall health, their robustness or frailty, but it's a nuisance for us in the estimation of kidney function. So for those with a nephrocentric view of the world, the most accurate way to get from creatinine to estimated GFR is to take any available demographic data and try to make an equation that gets us from serum creatinine to a GFR estimate. And that's what all of these equations do. And the ones that you're likely used to using for the last 20 years use age, sex, and race to go from that creatinine measurement to an estimated GFR. And I'll show you how we get there. Okay. So there's an inherent tension that I want to spell out that we work with every day. And those of us who work as epidemiologists as well as clinicians are perhaps more aware on a daily basis of this tension, but this is part of your daily life as a clinician or as a scientist, no matter what you do with your day. A clinician is interested in the individual patient and making sure that we get an accurate picture of kidney function for each individual patient so that clinical decisions can be made well. If I have an estimate that's too high, I might make the wrong decision by misdiagnosing by underdiagnosing kidney disease. If I have an estimate that's too low, I might withhold important medications, thinking that somebody's kidney function is too low for that medication. I might tell them that they have a disease when they don't have a disease, and that would be problematic. An epidemiologist is trying to understand kidney function and variability in populations in order to try to get an accurate picture of how a test performs and then provide data to a clinician. But the epidemiologist doesn't take care of the individual, right? And so doesn't know every piece of data about that individual to make a decision. And yet we rely on each other to go back and forth and to try to share data. Of course, the reductionist form of this is an N of 1 study. And of course, you can do an N of 1 study for something like kidney function by doing a true measured GFR, but that's not going to be an accessible test for populations. So let's actually look at a population and think about what we have when we think about data on a population level. What would an epidemiologist, a clinical scientist, have in order to make this leap from a measured creatinine to an estimate of GFR? So an epidemiologist looks at a population and they know the age of the individuals in that population. They know their sex, their gender identity. Race and ethnicity data are now required to be collected in all NIH-sponsored studies, and so we'll have people's self-identified racial or ethnic data. We'll have anthropomorphic metrics like height and weight. We'll have information on medical conditions and tests. We'll have a lot of data from blood tests and urine tests. We might even have genetic ancestry data from people's DNA. And in a study that's trying to understand kidney function, we might even have a measured GFR, a gold standard, if you will, to understand kidney function. But this only gives us a certain lens on our population, right? As a clinician, we might have more information about people. We might know what they eat. Now, vegetarians, it turns out, make less creatinine than people who eat meat, and a meat meal will raise your creatinine by about 0.5 immediately thereafter. So knowing about diet and even about what somebody ate the day before might be important for this equation. We might know more about people's exercise habits. Weightlifters make more creatinine than runners do, and runners make more creatinine than couch potatoes do. And so there's a lot more that we might want to know if we wanted to understand creatinine generation better. But, none of this tells us really about the richness of human diversity. And this photo is actually of our laboratory group. And in this group, we have a good age range. We have representation of women and men. We have at least 5 different countries of origin. We have vegetarians and meat eaters, runners and weightlifters, couch potatoes, and not. We have less diversity of educational attainment and income. We all have food availability, and we all experience the world differently and choose to live our lives slightly differently. But creatinine generation, as it turns out, is really a complex biopsychosocial structural marker of our bodies and how we live our lives. And so if going from this to real people makes you uncomfortable, that's sort of my intent. It's uncomfortable to have to generalize. And we really need to think a lot about what it is that we use when we generalize from a population to individuals and make these decisions on an individual basis. So with that preamble about cautionary tale of how little and how much information we have in trying to understand kidney function, I'm going to take you back to the first estimating equations for GFR, which were published, the first widely used ones at least, which were published in the 1970s by Cockcroft and Galt, two researchers working in Canada at the time. And they published this paper, one of the most highly cited papers in the literature until Andy Levy's MDRD study came out about the same topic 20 years later. So here's the abstract from the Cockcroft-Galt equation. This is a readily available population to these researchers in whom 24-hour urine's gold standard kidney function was measured. And they created this equation that uses age, weight, and serum creatinine to go from a measured creatinine to a creatinine clearance. So you'll notice that race is not part of this equation. And you'll also notice that there's a parenthetical comment in the abstract that one should subtract 15% in women versus men. Well, what was the population in whom Cockcroft and Galt developed this equation? This equation was mentioned again in the last year as one that would be a good race-free alternative to the current equations, which include race in estimating kidney function. But who are these 250 men who were used to develop this population? These were Canadian veterans in the 1970s hospitalized in a single veterans hospital in Canada. And this formula and all of the data behind it is developed entirely on a male population. And here's the sentence that, that generalizes this population to include women. Various authors have recommended reducing the predicted creatinine clearance by 10 to 20%. A 15% reduction appears appropriate. And so these are the men who stood in for all human population in the Cockcroft-Galt equation in the 1970s. And I did some work trying to figure out about the racial diversity of the Canadian military in the 1950s, 40s. And I found this photograph of the very first Black Canadian Air Force member in the 1940s. This was a military that was segregated not just by sex, but also by race. And so this population in Canada was overwhelmingly white, although there were certainly contributions by Indigenous individuals and Black Canadians. They were systematically excluded from the population. Nonetheless, this becomes the representative population in the Cockcroft-Galt equation, which is still used today for drug dosing. Now, at the same time, studies like the Framingham study in cardiovascular disease are being used to make landmark discoveries, really important discoveries about cardiovascular risk factors in the population. And Dr. Ix mentioned that I grew up in the Boston area. This is a map of the Boston area in the 1950s. Framingham is out here to the west on this map. But the part of the map on the right is marked off with the redlining areas in the Boston area, a very unfortunately racially segregated area of the country where real estate covenants prevented people of color from purchasing or renting homes in the Framingham area for many decades. And thus the Framingham study, which we think of as a representative population, which does include both women and men, was 100% European American by the design of these racist policies of the time. So this is not to take away from the importance of the work from Framingham and the work of the Cockcroft-Galt equation. These were important discoveries of their time, but by the time 1999 had rolled around, it seemed time to include more diverse populations in research and in representing all of us when we make epidemiologic inferences for kidney function or for cardiovascular disease. So in the 90s, there were a huge kind of proliferation of research studies that looked at multi-ethnic populations. The multi-ethnic study of atherosclerosis, the cardiovascular health study, the reasons for geographic differences in stroke study that enrolled people of African American descent as well as European Americans in the United States. And the Framingham study actually also moved on in the 90s to enroll a much more diverse cohort of individuals who had moved to Framingham as part of the Omni cohort. The real estate laws and the segregation in that town had lessened by this point, and so there was the ability to include a more diverse cohort. It's in this context that this MDRD study equation is published. And it's important to realize that until this point, we were still relying on the data from Cockcroft and Galt in general to estimate kidney function in medical settings. And this was published actually during my third year clerkship, and I remember it being discussed at Journal Club at that time, and people trying to figure out how to calculate it on their new Palm Pilots, if some of you remember that that era. So this equation was developed in a single study called the Modification of Diet in Renal Disease Study. And in this study cohort, every individual had a measured GFR. And so there was the ability to relate blood tests like serum creatinine to the measured GFR and try to account for what it is that made things different. So this study enrolled both women and men, and had two ethnicities identified, Black and white, and then looked at whether, and had a range of age as well, which is important for kidney function because as people get older, their GFR tends to go down. So here's what the MDRD study equation found. So indeed, at any given serum creatinine, kidney function was slightly worse as one got older, okay? And the assumptions that were made in the Cockcroft-Galt equation did hold true for women. So at any given serum creatinine, women's kidney function, measured kidney function was slightly worse. And the correction factor was not the 15% that Cockcroft and Galt had guessed at, but when measured was slightly different than that. And the investigators looked at whether there was a difference by the two ethnic groups that they had identified, Black or not Black. And they found that at any given measured serum creatinine, the measured GFR in their African-American subcohort was slightly better. And so using this set of numbers, they created this equation that used age, sex, and race to adjust measured creatinine and give an estimate of GFR. And I want to show you what they said in their discussion about why they included a term for ethnicity. Okay, and they say this equation seems to be more accurate than other equations tested, including comparing it back to the Cockcroft-Galt equation. It didn't require calculation of a collection of a timed urine specimen. It didn't require height or weight. And this is all important because these are harder to collect, right, than age or sex. And they thought this is important to include a term for ethnicity because kidney disease is more common in Black people, and we have not yet studied this. They say the demographic data are readily available, and a laboratory could compute this and report it on a lab slip. And so this is where we land in 1999 with the MDRD study equation, an admittedly small number of African-American individuals in a single study contributing to this race term in the equation. So what they say in their discussion comes true, and laboratories around the country start reporting an estimated GFR. And this does not go unnoticed. And this piece was published in 2011. Toni Martin, who is an African-American female physician in the Bay Area, a real pioneer, one of the first women to go to UCSF School of Medicine. And she wrote this piece called The Color of Kidneys. I distributed this to the medical residents because I think she was well ahead of the debate that went on over the last year in writing this piece. So she writes that as an African-American physician with a multi-ethnic practice, she knows that trouble is coming when she reaches the part of the panel that reports kidney function. Beneath the creatinine results is the GFR estimate with the instruction to multiply this number by 1.21 if the patient is African-American. And this is where my headaches begin, she writes. And this is what a lab slip that came out of this equation would look like. So a serum creatinine would be reported, and then these two calculations, either an instruction to multiply or the multiplication would be done for you and then reported out on the lab slip. And she writes, even if the eGFR correction factor succeeds in achieving greater accuracy for kidney function reporting, it may incur unforeseen costs by singling out a group that has faced scientific bias in the past. And so her patients and she question, why is this correction factor here? And why are there two estimates on this lab slip? Is the gain in accuracy worth the price of dividing people by a binary race variable? And so this was published in one of the prominent kidney disease journals in 2011. And I don't think it got as much traction until 10 more years went by. But the people who created the MDRD equation were already well aware that they had collected a very small number of minority population in that MDRD study. And they were working with equation developers around the world to create a larger cohort and to create a better study equation, a better equation that included a more diverse population of individuals, where we could make that leap between measured kidney function, serum creatinine, and a GFR estimate. So in 2009, the CKD-EPI equation was published using 6,000 people from around the world, 40% of whom were identified as African American, again recognizing the higher risk amongst this group of individuals. And at the same time, in cardiology, the ACA is working on calculators trying to understand different risk factors for different ethnicities and races in terms of cardiovascular risk. The African American population that contributes to the CKD-EPI equation is from a fascinating study called the African American Study of Kidney Disease. This was a population recruited around the United States, mainly from historically Black colleges and universities, but also right here in San Diego, where Dr. Gabai and others worked to recruit participants for this study of hypertensive chronic kidney disease in African Americans. And again, these were individuals who had measured kidney function, measured serum creatinine, and the work was done to make a relationship between those two things. And once again, in this 2009 equation, we find that there's a difference by sex and that there's a difference by age and race when we look at this relationship. And so, although the coefficients have changed slightly in this equation, the same three variables still are being used to move from a measured serum creatinine to a GFR estimate. Now in 2019, once again, the question arises, why are we using race in these estimates of kidney function when race is a social construct that we're using to calculate a biological variable? And Dr. Aniana and Dr. Wang and Reese published in JAMA a couple years ago an article that I think really did push this forward, along with a lot of activism from medical students and others to try to bring this to the fore. So they write that using race to guide clinical care is only justified if the use confers substantial benefit. And one might ask whether a 16% difference in estimated GFR is a substantial benefit, whether the benefit can be achieved through other feasible approaches, and whether people who reject race categorization can be accommodated fairly, and also whether the use of race is transparent. Now, the use of race is transparent in that report that I showed you from 2011, where there's two estimates on the lab slip. The use of race was not transparent in, for instance, EPIC or the VA medical record system, where race was pulled straight out of the demographic page, and an estimate was given on the chart that just used data that was being pulled from the medical record. So if we want to take race out of this equation, one way to do it, and I found this a very challenging part of the debate over the last year, what would be to move backward to the Cockcroft-Gault equation. And indeed, people suggested that that would be one solution to this problem. But recall that I just showed you that the Cockcroft-Gault equation was created in a population of individuals who are very uniform in many, many ways, most prominently by sex and race, but also just by dint of being part of the Canadian military in the 1940s and 50s. And I really feel like stepping back to that kind of world would be a step backwards in time rather than forwards, and would take diversity and say, you know, we'd rather move backwards in time. At the same time that the CKD-EPI 2009 equation is being developed in the United States, looking at African American and non-African American populations, equations are being developed around the world to go from creatinine to a GFR estimate. And based on what I've said so far, it shouldn't surprise you that the coefficients are slightly different in different populations, that age and sex contribute differently in different places, and that, this relationship is different around the world because creatinine generation is truly a biopsychosocial structural phenomenon. And when we move away from a uniform population, we learn that. So all of these other equations are being published to look at different populations. So then we come to the fall of 2021, when there's a real move forward, I think, a victory for equity in many ways. And that is the publication of the race-free 2021 creatinine equations. So this is the publication from last fall. And essentially, this is taking the same population that was studied in those 2012 equations and saying, what if we refit this equation without looking at, without dichotomizing by race, so that everyone is included together. And so this is what happens when one dichotomizes by race. Instead of looking at those two populations separately, we use everyone together. In the 2012 equation, the one that had been previously published, we get age, sex, race, and creatinine in the equation. And if we look specifically at those who identify as Black or African American, mainly those folks who were enrolled in the African American study of kidney disease, we find that GFR was overestimated in those individuals in the older equation by about 3.5 mils per minute of GFR. In the new equation that uses just age, sex, and creatinine, on average, this underestimates measured GFR by about the same amount in this population, but it gains the strength that this estimate is now done using the same three variables, age, sex, and creatinine for everyone. And the degree of error here is about the same in the other direction for the non-African American population. So there's some equity in terms of how inaccurate the new equation is, and the new equation doesn't include race. So immediately, the NKF ASN task force on reassessing inclusion of race of kidney disease says that this equation should be implemented in all laboratories in the United States. And indeed, this equation is already implemented here at the VA. It was almost a anticlimactic event. I thought I would get a lot of emails and comments, but our laboratory implemented it, and now only age, sex, and creatinine are used to calculate GFR at the VA, and that will be coming very soon to the UCSD system. It's coming to Quest and to other commercial laboratory systems very soon. So this race-free equation will be implemented nationwide by mid-2022, and we can ask ourselves if that is the end of the story. And I will tell you that it is not the end of the story. Let me switch gears for one moment and tell you about a parallel track that's happening in the pulmonary literature using the SOFA score. And for those of you who are critical care physicians, you'll know the sequential organ failure assessment score is used often to predict ICU mortality. And it uses serum creatinine, not adjusted for any other factors, as one of its terms. And in parallel to this discussion about taking race out of the estimated GFR equations using creatinine, there was a discussion about whether the SOFA score is systematically inequitable because on average, Black patients have higher creatinines than white patients with the same glomerular filtration rate. Wait a second, we just talked about this being a problem the other way. Higher SOFA score might disqualify somebody in crisis situations from being given an ICU bed. And so can it be the case that a SOFA score is discriminatory against Black patients because they have systematically higher SOFA scores and thus lower priority scores? So the question is being raised simultaneously in the literature on critical care whether the SOFA score should be adjusted for race, just as we're taking race out of the estimating GFR equations. Well, this is pretty confusing. So the SOFA score uses serum creatinine, and let's go back to our diagram about equity and equality. Problem with equality here is that on average, African Americans have higher creatinine for the same kidney function, and this leads to racial disparities. Okay, so an estimated GFR using age, sex, race, and creatinine is more equitable, but the problem over here is that this treats all African American people as if they're the same, and as if there is kind of a monolithic population that is the African American population with respect to creatinine generation rates. And this also leads to racial disparities. Okay, I can't see any of you, but I hope you look frustrated and confused at this point, because perhaps you thought that we were going to have a victory lap here, having removed race from one equation, and then realizing that in another place, not including race can be racist. So what do we do from here? Here's our timeline. We've tried moving from a monolithic white male population in Canada through to a much more diverse and inclusive set of people from whom we're trying to understand these equations, but we don't seem to be getting where we want to go. Here's the problem. We're actually solving the wrong problem here. Okay, when you start to see that you can't solve the problem with creatinine, with race in the equation, or without it, there must be something else wrong with the equation. And I'll tell you what's wrong with the equation. What's wrong is creatinine. Okay, creatinine worked great in a world where everyone was a male Canadian veteran, but it doesn't work great in our diverse world. And stop trying to fix it. Let's see if there's something better out there that we can study in a diverse cohort and that we can show is effective. So the step after equity is justice. And equity is about giving everyone a bike that fits, but justice is about giving everyone a bike lane to bike in. And so what is the analogy back to kidney function? It's a different marker of kidney function. It's cystatin C. And I'm going to tell you that cystatin C equations have been around for 10 years. We've just been willfully ignoring them. They were in this publication from 10 years ago. And you'll notice something really interesting about this equation. It never had race in it because cystatin C has a relationship with kidney function that is not different by race. Okay, there's a couple other subtle and interesting points here. There's less of a difference with each year of age. And if you worry about ageism in medicine and treating everyone of a certain age as if they're the same, then this is really important to you. And if you worry about sexism in medicine, you'll see that the coefficient for sex in this equation is also smaller. So there's a more generalizable relationship between cystatin C and kidney function than there is between creatinine and kidney function. Here's our kidney function timeline. Lots of equations. All of them have one thing in common, creatinine. Here's a similar timeline for the diagnosis and treatment of myocardial infarction. When creatinine was first measured in the 1800s, we were using white count fever to understand whether somebody had had a heart attack. And even during my professional lifetime, we've been through 4 versions of troponin, and cardiologists hop from one marker to the next as soon as they figure out that something's better. So the question is, why can't we move forward to include cystatin C as a more generalizable and better test of kidney function for our diverse world? Well, the truth is that we can move forward. It's been over 100 years. And if we cared enough about diversity, inclusion, and justice, we would move forward right now to use a different marker. So you might say, wait a second, I don't know anything at all about cystatin C. I don't understand how to use this, and I don't understand what it is. I am going to teach you in 30 seconds everything that you need to know. So cystatin C is made by nucleated cells, and it's filtered by the kidney. It's an endogenous marker of kidney function that's less affected by body composition. It happens to be more predictive of non-kidney outcomes, but that's not critical for our understanding for what we want to do here. What we want is to try to get a good estimate of kidney function. And so cystatin C at both the VA and the university hospital will come with an estimated GFR report. It is endogenously generated, and it is a biomarker, so it's affected by other things besides just kidney function. It is affected by obesity and thyroid disease. Importantly, it's affected by both inflammation and steroid use. And importantly, it costs more, probably about $5 versus 50 cents in truth, but more like $30 versus $5 from a Medicare charge standpoint. So the second recommendation of the NKF-ASN task force on race and kidney disease was to recommend national efforts to increase the routine and timely use of cystatin C. And we've tried to set you up for success in this regard at both institutions that we work at here. At both institutions, you can order a same-day cystatin C test, and it'll come back to you with an estimated GFR. I would argue that actually it's time to move on to cystatin C as our primary test of kidney function, not just as a confirmatory test. So what have we learned in this talk, and where do we go from here? We learned that we needed to move forward on kidney function measures, that Dr. Martin was right in 2011, separating people by race on a lab slip has an impact, and it was not worth any small improvement in accuracy that we had. It's important to study diverse populations. You can stop assuming that everyone is the same if you do so. You just have to be willing to confront what you see. Cystatin C, and this is what we see with cystatin C, is that it's inherently a less variable marker of kidney function across populations. And that is really important as we move to inclusive and just use of these markers. I'm talking to you, can order a cystatin C estimated GFR today in the clinic, on the wards, at either of our main institutions. And we can consider this to be a race-conscious measure of kidney function. When we took race out of the creatinine equation, it moved us forward in some ways, but it didn't solve the underlying problem with creatinine. And equity is not the same as justice. We don't know how to implement cystatin C testing nationwide, and we haven't fully confronted what it means about cost. Cost usually goes down as things scale up, but we have not yet fully identified this. We don't know fully how to use cystatin C on an inpatient basis. We don't have as much clinical information or experience with it, but I would remind you that you didn't have as much experience with troponin when it first came out, and you're not still asking for an LDH. And this is really key. And I want no one to walk away feeling that we have solved the larger racial inequities in kidney disease. And I want us not to be distracted by this effort from the larger problems that have 3 to 4 times the number of people progressing to end-stage kidney disease in the African-American population than in the non-African-American population in this country. And Dr. Ojo, who was one of the founding people involved in the African-American study of kidney disease 20 years ago, wrote scathingly about this in the Annals of Internal Medicine a few months ago. And he calls the effort to eliminate race from estimating equations in GFR a product of tunnel vision, ignoring both history and science, and is concerned that this represents tokenism that will have no materially significant effect on kidney health inequities experienced by Black patients today, tomorrow, or a decade from now. And that what we really needed to do was not adjust our estimating equations, but improve our healthcare and public health systems to truly eliminate inequities in kidney health, rather than simply to more precisely or more equitably measure kidney function. So what doors remain to be opened? The doors that remain to be opened, I envision as kind of a CKD Epi 2041. What is it that my daughter's generation will want us to have done by the time they are of age? So we might be still reading or listening to NPR and hearing about kidney function tests that don't work well in more than half the United States population, because we today were not comfortable with paying for them or not comfortable with getting familiar with them. We might be reading in the New York Times about how doctors 20 years ago used cost as an excuse to deny more accurate testing and to move forward. But I hope that we'll be reading editorials like this, hope for more than one reason, that my daughter will be able to write that she was concerned that when she entered medicine, she would wonder if the legacy of suffering from lack of access to diagnostic and preventive treatment for kidney disease would continue. I hope that she can write that thanks to our generation, many of the structural gaps have been closed, not just in early detection of disease, but in making healthy food, water, and environments accessible to everyone. So I hope that we can read that in the future. So how can you take this into action in your daily life as a clinician or as a researcher? Well, first of all, think about whether your patient is at risk of an inaccurate estimate using creatinine. Were they part of the population studied for the equation? Are they unusually frail or unusually fit? And assess whether your patient is at risk of kidney disease. If they are, please measure a cystatin C-based estimated GFR. And while you're at it, get a urinalysis and a urine microalbumin to assess whether they have proteinuria, because that tremendously increases their risk of kidney disease progression. At a systems level, why don't you think about whether the system that you work in makes it possible for minoritized populations to access and engage in preventive care? We don't want anyone to have to meet a nephrologist, really. We want this to be done in a preventive fashion so that no one has to suffer through kidney failure. Assess whether there are communities that you can reach out to and talk to and work with. And let's measure success not in terms of 3 milliliters per minute of GFR, but in terms of community level knowledge and health improvement. And that will be how we move forward. I offer you some recommended reading. The Mismeasure of Man is a book by Stephen Jay Gould that talks about how we only are as good as our social context when it comes to translating measurement to people. Toni Martin's autobiography is an incredible read called When the Personal Was Political, 5 Women Doctors Look Back, about her years at UCSF School of Medicine. Vanessa Grubbs has written an autobiographical memoir of her donation of a kidney to her husband and her work as a nephrologist. And as an advertisement, as part of Black History Month, next week, Isabel Wilkerson is speaking here on caste and its role in health inequity. And I will stop there and ask for questions and thank my wonderful colleagues in this picture and others who I've worked with over the years.
Dr. Rifkin, thank you so much for that thought-provoking and really fascinating, important work that you shared with us today. There are a couple of related questions that I wanted to ask. Thank you. From Dr. Mohammed and from Dr. Mullaney. Great talk. You mentioned that there are variables that impact cystatin C. How do they impact our ability to estimate GFR? And similarly from Dr. Mohammed, thank you, Dr. Rifkin, for pointing out the inherent inaccuracy of using a binary race variable in an equation to estimate kidney function. Regarding the use of cystatin C as an alternate method, I've noticed in several clinical scenarios that the eGFR estimated by cystatin C varies greatly from the eGFR estimated using serum creatinine in the same patient. My instinct is to use the estimate derived from cystatin C, but nephrologists have told me that the renal function in these cases is likely somewhere in between the two estimates. Can we trust any of these eGFR estimates? And is there light at the end of the tunnel when it comes to accurate measurement of renal function?
Sure. So, the E is for estimate. So we're trying our best to get as close to kidney function as we possibly can. And because these are both endogenous markers, they both have their troubles. Now, we're most used to the troubles of creatinine because we've used it before. So when I walk into a patient's room and I see that they're a double amputee, I know that their creatinine is, that their estimated GFR is not going to give them an accurate measure of kidney function, that it's going to overestimate, okay? The issues with cystatin C are ones that we are less comfortable with so far because we haven't used it as much. I'm very actually thrilled that somebody can ask the question that who has measured this enough to have seen differences, right? So in obese individuals, there's more cystatin C generated, so those estimates would go in one direction. In people who are on steroids, the same thing happens, right? So the cystatin C can be falsely elevated and thus the estimate falsely low in those settings. We are engaged on the research side in studying what that difference means. So we are very engaged in what we're calling the eGFR diff, which is to say, what happens if your cystatin GFR is better or worse than your creatinine GFR, and which should you believe? Now, for full disclosure, I'll tell you that there are estimating equations that include both cystatin and creatinine, and on an overall population level, those equations work best. But I care about individuals, and I would say that what we learn from that difference in individuals is that if the estimate from cystatin is higher, that individual is likely to be somebody who is a high creatinine generator and healthier, right? That their creatinine is elevated, unlikely because of kidney disease, but more likely because of higher creatinine generation, and they're just a more robust person. And the opposite would be true if the opposite were true. So somebody whose cystatin GFR is lower than their creatinine GFR is likelier to be frail and to be of higher risk for other reasons. I hope that answers those two questions.
Thank you, Dr. Rifkin. From Dr. Adishu, thank you very much for this excellent review. Can you comment on drug dosing? I know you just mentioned this briefly. Currently, the FDA requires Cockcroft-Gault estimates for drug approval submissions.
Yes.
The PK data is analyzed based on pre-specified categories of kidney function using Cockcroft-Gault. The issues of applying different equation estimates, de-indexing body weight, and now different biomarker estimates to drug dosing creates large discordance in drug dosing.
Yes. So Dr. Ardishu is exactly correct. This is so the long arm of history is that Cockcroft and Gault remain the standard for drug dosing. And to give those two men some credit, I don't think that their intention was that their equation would still be being used 50 years down the line for this. That was not the intention. It was, each piece of research is a step forward, but, it was a simpler world when the Cockcroft-Gault equation was being used. But one might ask, have we just been misdosing drugs or miscategorizing people? And fortunately, many of the drugs we use have wide therapeutic ranges, so we're okay there. I think that we're going to move to using other equations to get FDA approval. I think that the FDA has heard all of this, but I don't think it's happening soon, and I think it's very complicated. Now, how precise we need to be is another whole question, right? Does it really matter if your GFR is 36 or 39? Well, it only matters because we try to dichotomize things. as clinicians, right? We try to say at an estimated GFR of 30, we must stop this drug, or an estimated GFR of 20, we can list for kidney transplant, and not below and not above, right? So anytime we take a continuous variable and dichotomize it or divide it up, we run into this kind of problem. Oh, you are muted.
Perfect. Thank you, Dr. Rifkin. Sorry.
That's okay.
A question from Dr. Saine. Excellent talk, Dr. Rifkin. How would you suggest communicating these nuances related to different estimates of kidney function by race to patients? For example, when they see the results in EPIC and wonder why the estimates are different by race.
Yes. So, very important. So I think that one of the real wins of taking race out of this equation is that report no longer includes two numbers, or no longer includes, and we adjusted this for race, okay, because of that impact that Dr. Martin talked about in 2011. So I think that this will be a real step forward. Now, how are you going to explain to your patients when their serum creatinine measurement is the same next month as it was last year when they saw you, and all of a sudden the estimate has changed? Now, here is where I can mention our anti-racism coalition at the medical school, who are putting together patient-friendly handouts and guides on this topic to be distributed when UCSD goes live with these equations. So shout out to them for being ahead of this curve in terms of developing patient-friendly materials. Those are also going to be more widely available on the NKF website. So we will have tools to help explain this to our patients.
Excellent. And I know we're out of time, but just one more question from Dr. Rubin. To improve healthcare, should the addition of genetic information at an earlier patient age be used to identify patients with particular risks?
Yes.
APOL1, a gene related to resistance of trypanosomiasis brucei gambiense, is associated with kidney disease. In a similar fashion, there are several genes related to hypertension for which Africans are at particular risk.
Yes.
Knowing genetic variabilities may be useful in ultimately the recognition of patients with particular vulnerabilities.
Yes. So, so an important comment is that the African American study of kidney disease is really the place where that APOL1 gene mutation and its effect on kidney disease progression was identified, and it is more common in people of African ancestry. It doesn't affect this particular issue that I just talked about. So kidney function estimation is kind of different from potential genetic risk for kidney function, for kidney disease progression. And we are moving forward to start to include potential for genetic testing for APOL1, particularly in the setting of kidney transplant, but in other settings as well.
Thank you so much, Dr. Rifkin. This was fabulous. We're so grateful to you. I hope all of you will join us next week for Department of Medicine Grand Rounds.